So I'm very pleased to have Dr. Gagnon and Basset join me in discussing some of the key takeaways from our first chapter of our educational activity here. I guess, I think it's such an interesting disease and an interesting time in the field in terms of thinking about how we target the mechanism of disease. Uh, Dr. Basset, do you have anything to add in terms of, thinking about how we target the repeat expansion or other steps?
Yeah, so this is exciting time regarding therapeutic developments, and the good thing is that we know that more than one strategy and mechanism of therapy exists. So, as you mentioned, the main one, since this is a toxic expansion disease, that is the gain of function is mainly mediated through the RNA. So, targeting the mutant RNA expanded transcript makes sense and is the core of the therapeutic development. But uh, fortunately, we know that other alternative exists. So there might be other strategies that can reduce the transcription of the MPK mutant gene, and that could also increase the level of muscle blind 1, which is the main regulatory factor as a modulation of the uh, splicing defects. So the good news is that there is more than one strategy here.
Yeah, I think it's really an exciting time. Thinking thinking a little bit about, the discussion of, this is really an autosomal dominant disease in the sense that it truly affects a whole family. And, I guess, Dr. Gagnon, do you have any thoughts or what's your strategy for approaching multiple generations, a large family with myotonic dystrophy type 1 in terms of talking about the diagnosis, how to get people tested, that kind of thing?
Yeah. I think at the moment it's still a very challenging period in terms of diagnosis because oftentimes, even in a province where there is a higher prevalence, we still see general practitioner, neurologists, genetic counselors that do not go over familial screening. Where understanding that if you have a child with myotonic dystrophy, then you need to have a global genetic counseling for the family and even the extended family. And I think that that's one very important point as being an autosomal dominant disorder. The other point that is very important is that you're not only managing one individual, but you are managing several members of the family, where oftentimes the mother will be highly affected by the disease and maybe not in the capacity to take in charge all the multisystemic management of the affected child and will need additional support.
Yeah, I think that's a great point that you really do have to, find a particular individual or stakeholder in the family who can kind of lead that family's care. So I think, in terms of thinking about the overall disease burden, I know, Dr. Basset, you're going to speak about this a little bit more, but other thoughts in terms of, you know, how do we how do we identify these patients earlier? It's such a high prevalence, and we just know that we're missing people out in the communities.
Yes, that's a big issue among regarding such a heterogeneous disease. Uh, r- Ranging from birth to the 80s. Uh, the first concern is that it is so heterogeneous that makes it difficult to recognize for physicians. Uh, as Dr. Gagnon mentioned, there might be a good option through genetic counseling now, since having diagnosed one individual makes possible to diagnose relatives. And so the diagnosis could extend from one patient to a whole family, considering the autosomal dominant inheritance. Another important thing is that due to the genetic anticipation, when we go to relative, there might be some poorly symptomatic or either asymptomatic individuals. So it creates another challenge that the disease cannot be recognized in genetic carriers, why themselves can transmit the disorder in a much more severe way and with manifestation at the next generation. So this is here a high need, and genetic diagnosis is for sure a challenge.